Okay, good evening, everyone. My name is Dr. Mahmoud Taha. I'm a consultant neurosurgeon with interest in neuro-oncology in King Fahd Specialty Hospital in Dammam. And today I'm giving this talk on the new classification of CNS tumors in adults. First of all, I'd like to thank the scientific committee in SANS, the Saudi Association of Neurosurgical Society, for giving me this opportunity to present on this platform. We will start with, starting with the outlines of the talk. We will be covering, first of all, there will be introduction on the overview of the primary brain tumors. Then we'll talk briefly on the old classification. Then we'll move on to the new classification of WFNS with some case presentations. I have nothing to declare in terms of conflict of interest. Now, the brain tumors are divided, as we all know, to primary and secondaries. Okay, and these are the subtypes or the pathological types of primary brain tumors. You can see in the screen. Majority are gliomas, around 40%, 30% meningiomas. We have pituitary, vestibuloschwannomas under nerve sheets topic. We have other tumors. And these are the common tumors in adults. And we all know there's, different subtypes or different pathologies that are more common in children, like medulloblastoma, gliomas, and ependymoma. So this figures that we've seen here is the overall brain tumors, primary brain tumors in all ages. And this is from the US. Now, in terms of how the percentage of the malignant tumors in primary brain tumors, it's about 40 or 50% of the primary brain tumor are considered to be malignant. So almost half of them are cancer, okay? But it's good to know that the brain cancer in relation to the rest of the body is not common. And this list this is actually local. This is a national study from the Saudi Cancer Registry. You can see that brain cancer is number 10, okay, in terms of the distribution in male, female, and this is for all ages, okay, all different ages. So it's number 10. So it's not common. It's not as common as breast in female or colorectal in male. Or lung cancer, etc. In fact, if you exclude pediatric and we focus only on adults, it constitutes only 2% of all cancers. However, in kids, it's it's the second most common, as we all know, following the hematological cancers. It's about 20–30% of all cancer in kids. So there are differences between adults and pediatric, and that's why this topic, it would be divided into adult and pediatric. So we'll cover this lecture. Will cover only the adult, overview of the new classification adult, because the pediatric will have a lot of information that would need to be covered in different topic. And it's worth mentioning that even the molecular, bases for both tumors are different. For example, glioma. Glioma in adult is different from glioma in pediatric, and we'll cover this later on. Now, it's really important to mention here also that there are variation in the incidence of brain tumors between countries. And the incident per year, per 100,000, vary from country to country. So it's roughly between 2 to 7 to 8 per 100 per 1,000. It's more common in the Western countries like Europe and North America. And if you see at the graph on the left, this is from the UK, the Cancer Research UK. And on the right is it's a local study that we have here. Now, we all know there are two peaks for brain cancer or brain tumor. one in the pediatric first 5 years, and then another peak in the 60s and 70s. Now, in our local studies or in the Cancer Registry Saudi, we found that this is slightly different. First of all, in Saudi and Middle East, the incidence per 100,000 is less. Okay, it's not as common as in the Western, North America or Europe. However, the peak or the age that's affected by tumor is slightly different. The tumors in the pediatric population is slightly higher. The second peak in adult is in a younger population, the 40s and 50s. So gliomas, mainly GBM, we see them here in the younger population, where in the UK, for example, where I used to work before, they were normally in the majority were in the 60s and 70s. So it's important to mention there are variation, okay? Now, how do we classify brain tumors and what system do we use? We have two systems to classify brain tumors or collecting data on brain tumors. We have the ICD, International Classification of Diseases, and the latest version is ICD-10. And we have the WHO system, okay? The ICD system is used by cancer registries mainly and hospital administration records. It's very useful for administrative purpose, but not for clinician. For clinician, we use the WHO. And it's worth mentioning here that the ICD only collects cases that have pathologies, okay? However, there are cases of brain tumor we can treat without pathologies. For example, brainstem glioma, optic nerve gliomas, we can treat them without pathologies. Some meningiomas, for example, we'll treat them with stereotactic radiotherapy without pathologies. That's why the ICD or the cancer registry might not cover all cases. But if you have, for example, MDT, office or MDT facilities, you can collect more cases. You cover everything, like what we have here. And you can see also the difference between the classifications between ICD. This is a nice table show that some cases documented or recorded as malignant in the ICD, it was not in the WHO, because this category is included the grade 1, some of the grade 2, and vice versa. So we have to be careful when we read the ICD classification of brain tumors. The WHO basically used this grading, which we all familiar as residents. You should be familiar with this criteria for grading. We have 4 grading, starting from grade 1, 2, 3, 4, depend on the presence of a tibia, aneuploidia, mitotic activity, microvascular proliferation, and necrosis. And this is all known to everybody in, as a resident in neurosurgery, and I don't want to go through them, okay? Now, the WHO, the old one, what was the problem with it? Well, the problem with the old one, the pathological diagnosis is based on microscope, light microscope, and H&E staining, okay, and also using some special, immunohistochemistry markers, without looking into the genetic basis of the tumor or the origin of the tumorogenesis of the tumor, if you can call it. And that was led to a lot of confusions between pathologists. It's also important to know that there are also pathological variation in reporting tumors based on the old one, and this depends on the expertise. I mean, we used to get patients, for example, reported from the other hospital, like previously before the new classification as ependymoma, but when our neuropathologists reviewed it, it was medulloblastoma. Okay, so there are variation between pathologists, depending on their expertise. And this is because the diagnosis here is based on light microscope and limited number of markers, without going into a specific, moleculars that follow the tumorogenesis, of the pathology. And that's why, since we have, this research the last 10 years or 15 years, the intelligence or, the scientific community moved to new classification, which we'll try to cover today and explain the difference between the new one and the old one. Now, this is the old one, okay? This is summary of the old one, which we all, as residents, need to be familiar with. This is the common tumors that we face in neurosurgery. The bold classification, this is what we taught as residents, as the old generation. It's either neuroepithelial tumor and non-neuroepithelial tumors. The tumors of neuroepithelial mainly include tumors that arise from the brain tissue itself. So glial cell, neural cells, okay, or choroid plexus. It includes also pineal gland. It also includes embryonal tumors, because some consider these tumors or these cells coming from the stem cells, of the nervous system, and that's or embryonal cells of the nervous system. That's why it's included in the neuroepithelial. So we have neuroepithelial, non-neuroepithelial. This is the tissue coming outside the brain, or tumor arising from outside the nervous system or the brain itself. So meningioma, mesenchymal, the peripheral nerves. Also, it's not considered as neuroepithelial, like vestibuloceanoma, stellar region, pituitary gland tumor, germ cell lymphoma. This is from the bone marrow and the blood. So non-neuroepithelial. Now, I want you to focus on the neuroepithelial here, the glioma. Okay, now the glioma here in the old system, it's collected under one group, astrocytoma, oligodendroglioma, mixed oligoastrocytoma, ependymoma. Astrocytic tumors with different grading from 1 to 4 include the pilocytic, pilomyxoid, diffuse astrocytoma, which is grade 2, anaplastic, then the glioblastoma, GBM, gliosarcoma, gliomatosis cerebri. So this is one group. Okay, this is all considered to be one group. Okay. So remember this list, and then we're going to move to the new list, and then we'll see the difference. Okay, or the differences between them. So why did we move to the new WHO classification? Well, we moved because we have huge advances in the molecular and genetic studies for all these tumors. We have found genetic markers or molecular markers that is relevant to the diagnosis and prognostication of the tumor. And this has really helped to better classification, understanding the behavior of disease and their survival or the prognosis. So what we are included here on the list is actually the most relevant, clinically relevant tumor markers. IDH, for example, this is, it's a must now. Co-deletion, TP53, less important, TRT. H3K27M, this is also essential. This will be covered, so I'm not going to cover this in this topic. In this lecture will be covered with the pediatric tumor. Our main focus mainly on the adult gliomas. Okay, but remember, these are the markers that we should be familiar with, mainly the IDH and the co-deletion, which you need to remember them very well. It's really important to remember that the separation between adult and pediatric is not only on the distribution or incidence of tumor, it's actually also the molecular, and that's why we have to study them separately. Now, knowing that we have new tumor markers or genetic markers, we need now to use with them a new terminology to describe tumor. Previously we used to call it diffuse astrocytoma, WHO grade 2. Okay, this is not enough now. Now we need to add to the histological name or histopathological name, it need to be followed by the genetic feature or the genetic mutation alteration. For example, we have diffuse astrocytoma, IDH mutant. Okay, sometimes you have two genetic alteration, like the oligodendroglioma. So you have to say it's oligodendroglioma, IDH mutant, and 1p19q co-deleted. Okay, so this is now the new language we need to use, or you need to use, and everybody has to be using in a neurosurgery to describe tumors. Okay, histopathology followed by genetic mutation. So if the tumor is lacking this genetic mutation, what did we say? We say this genetic mutation is wild type. For example, glioblastoma. We have two types of glioblastoma. We have the IDH mutant, IDH wild type. So wild type, that means this genetic mutation in IDH is not is lacking, is not present. So we can say we don't say it's negative. We call it IDH wild type. Okay, for this kind of description, for this tumor. Now, sometimes you don't have genetic mutation, you have alteration. So it's a minor change. And this is when you use positive or negative. For example, ependymoma. This is a new entity that's been added, especially for supratentorial ependymoma. This marker is called RELA. So it could be RELA fusion. So it is negative or present. If it's present, it's positive, sorry. If it's not present, it's negative, okay? Similar to BRAF fusion, it's negative or positive, okay? Now, the last thing, which is really important, if your lab doesn't have the facilities to do these tests, so this lab need to report the tumor as none otherwise specified. So you use the histopathological diagnosis, and then you say NOS. That means when other pathologists, anybody read this report, he knows that you don't have the facility to do the testing, okay? So this is the language we need to use. So you can say IDH mutant, wild type, negative, positive, for alteration, not available, NOS, okay? Now, let's start with the changes now. What's happened next, okay, in the new WHO classification, and I'll go through them, group by group, and then tumor by tumor. Very simple. I'm not going to use complex genetic descriptions. We're just going to focus on the clinical implication or the clinical use. Because we don't want to make it difficult. And I'm not going to put any pathology slides, okay? This is only a simple an overview for everybody to understand. This is just the basics, okay? And everybody needs to know how to use the new classification and what is changed now. Now, let's start with the glioma. So for glioma, we have the astrocytoma now, astrocytic cells tumors, okay? Now, the astrocytoma is divided into two groups. The first group, diffuse astrocytoma, which has the IDH mutation, or they call the IDH mutation family, okay? This will include majority of the diffuse astrocytoma, grade 2, and 3, anaplastic astrocytoma. It will include also oligodendroglioma and few of the, less frequently, the glioblastoma, okay? Now remember, glioblastoma multiforme, GBM, we don't use them anymore. We call them glioblastoma, okay? Now, the same group, if you don't have the IDH, so it is the wild type, and it's mainly most of the glioblastoma, okay? So we have the IDH family. This is a tumor that is infiltrative diffuse astrocytoma, okay? Now, the other group now is the circumscribed growth pattern astrocytoma. These are the tumor that we know surgically when you operate is well defined. There's a clear outline. It's not like the diffuse astrocytoma. I'm talking about pilocytic astrocytoma, okay? PXA, subependymal giant cell astrocytoma, the SEGA. These tumor well defined, and they are they are different from diffuse astrocytoma for a reason, because they have a different genetic alteration. Okay, this family doesn't have IDH gene mutation. Instead, most of them have the BRAF alteration. Okay, so this BRAF alteration include majority, it's the polycystic astrocytoma, pylomyxoid, PXA, or they have another mutation, is the TCS1, 2, for the subependymal giant cell astrocytoma. So now for diffuse astrocytoma, for astrocytoma, we have two groups, the diffuse astrocytoma, and this we'll talk more about it now, we'll show some cases, but for the pilocytic, they will be covered in the next topic, okay? So two group now for astrocytic tumor. Now, again, so what we're gonna end up now, we will end up with, for the diffuse astrocytoma, which is the grade 2, diffuse astrocytoma grade 3. Now we have new terms, okay? Diffuse astrocytoma grade 2. It's either, majority of them, it has to be IDH mutant. So diffuse astrocytoma, IDH mutant, that's one entity, okay? One variant of it is called gymnocytic. Okay, so gymnocytic IDH mutant, it's one variation of diffuse astrocytoma. We used to have a lot of variation in the subtypes of the diffuse astrocytoma, like protoplasmic or fibrillary. It's been removed. Okay, it's apparently it's actually just one group. Okay, but the pathologists accepted only the gymnocytic variant because it does have special features. For the others, been removed now. Okay, so we have the astrocytoma. So diffuse astrocytoma grade 2, it's normally IDH mutant. The wild type is very rare. Okay, and you have to be careful when you say diffuse astrocytoma IDH wild type as a low grade. And then if you don't have the test, it's the diffuse astrocytoma NOS. Okay, so these are all the division or subtypes of the diffuse astrocytoma. Anaplastic, same thing. IDH mutant, majority, very rarely we call them wild type. And then NOS, okay, when you don't have the test. Now, it's really important, a lot of studies talking about, about the prognostication for grade 2 and grade 3 in diffuse astrocytoma, especially with IDH mutant. And apparently, a lot of studies that suggested that the prognostic difference between them is not marked, is not very obvious. So when you have a diffuse astrocytoma, grade 2, grade 3, IDH mutants, the management and the prognosis is probably similar now. Okay, so I think in the future they will include them in one group. Okay. So what about the oligodendroglioma? What is the possibilities for oligodendroglioma? The possibilities now is one. The oligodendroglioma now, the definition of oligodendroglioma, which is extremely important, is to have, first of all, IDH mutants. It has to be in the family of the IDH. Second, co-deletion, 1p90q, has to be present. If you don't have co-deletion positive, you cannot call this tumor oligodendroglioma. And this is new. Previously, you can say the description of oligodendroglioma is pathological on the microscope. You don't need to wait for the co-deletion. But this is not acceptable anymore. You need to do the co-deletion, and you cannot call oligodendroglioma now unless you have the co-deletion. And this is important because prognosis is very good, in oligodendroglioma. So no co-deletion, it's astrocytoma, it's not oligo. Okay, and last thing here I need to mention, which is again important, oligoastrocytoma, it's better not to be used. It's better to be stopped. No more oligoastrocytoma. So you do the IDH, you do the co-deletion. If it is positive, it's oligo. Negative is astrocytoma, diffuse astrocytoma. No more oligoastrocytoma. Okay, if part of the tumor has the co-deletion positive, the whole tumor is going to be oligodendroglioma. Okay. Now, glioblastoma. Glioblastoma, not GBM, glioblastoma. Glioblastoma, okay, this is where we need to explain the change in terms, because glioblastoma, we used to call them primary and secondary. Now, where's the primary and where's the secondary now? Glioblastoma IDH wild type. This is your primary or de novo. Okay, so when the IDH mutant is not available or is not present, it's wild type. This is the primary. That means it's the primary de novo glioblastoma. Okay, and it has some variants. You know, it's still considered here the giant cell glioblastoma, gliosarcoma, epithelioid. It's a new entity. I'll show a case soon. The IDH mutant glioblastoma, so this is what we used to call secondary. So this is a transformation from a grade 2 or grade 3 diffuse astrocytoma. Okay, so this is how we correlate the old one with the new one. Glioblastoma NOS, we don't have a test, okay, for IDH. We call them NOS. Now, again, very important, there's no more gliomatosis cerebri. Okay, this term should be stopped. I know a lot of people like to use, especially our neurology colleagues, the old, the senior guys, they love this term. Whenever they see diffuse multiple lesion, they call it gliomatosis cerebri. Well, guess what? It's not there anymore. It's either multifocal GBM, or sorry, I shouldn't be using GBM. It's glioblastoma or anaplastic astrocytoma or diffuse astrocytoma, multifocal disease. Okay, so no more gliomatosis cerebri. You do the biopsy, and then if it is GBM, oh sorry, glioblastoma, it's multifocal glioblastoma. Very important. Okay, so this is a case of a man in his 40s presented with headache and vomiting, and the scan showed lesion at the corpus callosum. You can see on the sagittal view here with contrast, and there are a lot of leptomeningeal enhancement and seeding, and I thought this probably a metastasis with seeding, leptomeningeal, filtration. And we did a biopsy, and for my surprise, our neuropathologist told me, or reported as epithelioid. I've never seen this case before, but apparently she told me it's a new variant of GBM. You have a leptomeningeal seeding. It is very poor prognosis. Survival of this guy who had, after the biopsy, radiation, chemotherapy, was less than 6 months. But it's a new variant, and it's interesting. So this is now very, very important for the final diagnosis of astrocytoma. Okay, so astrocytoma, this is how you divide them, how you get the final pathology. You start with histology. Okay, so you can grade them initially: astrocytoma, oligoastrocytoma, or before the markers, oligodendroglioma, and then glioblastoma. So this is your initial step, histological diagnosis. And then you have to do two things: IDH and the codeletion. Okay, IDH, if it is mutant, go to the next, the codeletion testing. Okay, you can see here, IDH mutant, codeletion. Positive, both, this is oligodendroglioma. Okay, grade 2, grade 3, you can decide, your pathologist can decide. This is also important to confirm the diagnosis, but it's not essential. Okay, what is essential is the IDH, the codeletion. So IDH mutant, codeletion negative. Okay, so it's diffuse astrocytoma, IDH mutant. And this is the majority of diffuse astrocytoma, grade 2 and 3. IDH is wild type, negative. Okay, so if it is in this group, not aggressive tumor, if it is grade 2 or 3, you have to be careful. IDH wild type, normally, it means either it is glioblastoma, a very aggressive tumor, or could be different entities. So you need to make sure you excluded different entity like, PXA or ganglioglioma, okay, before you call diffuse astrocytoma IDH wild type, okay? So you have to be careful. Glioblastoma, okay, wild type mutant, glioblastoma mutant. That means it's a secondary GBM, the transformation more likely. IDH wild type positive, sorry, negative, it's wild type, so it's glioblastoma IDH wild type. Okay, you don't have the testing, NOS, all of them. So two important markers, the IDH and the co-deletion, to make a definitive diagnosis. Now, I'm just going to mention to you this study that we did in our hospital, in our lab, going back to all anaplastic glioma tumors before 2016 to see how accurate was our old system in the final diagnosis of tumors. So we collected all the anaplastic astrocytoma and oligodendrogliomas that we had before 2016. Then we examined them again by using the new tools, the IDH and the co-deletion testing. And this is still ongoing, it's not being done. We don't have final results yet. So this is 6 years before 2016. Then we did looked at the pathological diagnosis based on the old one. And then we did further testing to see the final diagnosis based on the new WHO, okay? And for our surprise, we found that nearly 40% of the cases that have been reported based on the old system were incorrect. Okay, so for a lot of oligodendroglioma, it used to be called oligodendroglioma, but these tumors were behaving badly. And when we did the test co-deletion later on, it was not positive. It was not co-deleted. It was not actually oligodendroglioma, and vice versa. And this is again similar to another study which I've seen recently. I think it's Austrian, and they found same thing. 30% they had the wrong diagnosis. When you don't choose the markers, the tumor markers. And I'm giving you some examples here. So this is one of them from our study. This guy, this is an interesting case because this guy came to us with this lesion on the right temporal. He was 57. I remember him in 2012. He came to us. I remember him because he was a physician. This is the MRI scan, T2 and T1. And the contrast, it's not very marked enhancement. And we told him, look, this lesion is resectable, it's small, and I think it's better to do surgery. But I think somebody else advised him, no, it looks like low grade, just leave it and we will watch it with another scans. So a few months later, he came to ER with increasing headache and vomiting. And obviously you can see the changes, the new changes in the progression, the fast progression of the tumor, necrosis, and there was also some bleed in the tumor that indicate that this tumor is not, is not behaving in a nice way. So we took him for urgent debulking and took out or drained all these. There was some blood and drained the the necrosis and the clot, and we've sent it to the lab, and the pathologist reported it as anaplastic oligodendroglioma, WHO grade 3. This is in 2012, so that was before the new WHO classification. Started on radiotherapy and chemotherapy. Again, this patient didn't do very well. It wasn't behaving like oligodendroglioma, because 6 months later, in the follow-up scans, this is what we found. Fast recurrence and progression of the disease, looks even uglier now. And we advised another surgery because it's still focal disease, and he's youngish. So the pathology this time came back as glioblastoma. And his overall survival was similar to a glioblastoma case. So from the start, we reviewed, as I said in the study, we reviewed his pathology again, and the co-deletion was negative. So it wasn't oligodendroglioma. That would explain why the tumor behaved really in a nasty way. The IDH was wild type, so it's behaving like glioblastoma. When we knew, when we had the pathology initially, we were told it's oligodendroglioma, and we relaxed a bit. But if we have these markers, we would have informed the family, this is really ugly tumor. It's not going to be, a good prognosis. We could have been maybe more aggressive. So this is an example how this new tools that we have now is useful for prognostication. And this is another example from the study that we have. This is a young man, actually. He's only 21, came in with headache. And in 2013, he came with this lesion, the T2, T1, with contrast, and you can see minor enhancement in the depth. The father was very reluctant to have a major surgery or resection initially, and I told him, okay, let's do biopsy at least to know the grading and the type of tumor, whether it's actually astrocytoma or something else. Well, it looks typical for astrocytoma, but anyway, we did a biopsy. It came back as diffuse astrocytoma grade 2. The patient did well after surgery. So the father said, okay, well, can we do the resection now? Because, he saw that, the patient was okay after surgery. So he trusted us. So we did the surgery, resection, and the pathology came back as anaplastic astrocytoma. Okay. So this is a good teaching case to see, to explain why, taking a biopsy from suspected low grade might not be enough. You could take a biopsy from the low grade part of the tumor. And if you have a tumor which has some enhancement, it's always better to biopsy the part which have enhancement, because that will be more representative. That's lesson number one. And number two, for low grade, if it's a resectable area, by the way, we did functional MRI for this guy, and he's right-handed, so it's not dominant. It's always better to do resection for better survival, as a lot of studies shown, even for low grade. Bigger biopsy, you can do the moleculars as well. So this patient had the surgery in 2013, and for some reason our oncologist decided just to give him radiation. They didn't give him chemotherapy. However, 6 years now, there's no recurrence. We went back. It was still co-deletion negative when we tested it again, but the IDH was mutant, so it was a good behavior of a tumor. So this is another example to show you how these tools is good for our prognostication and survival. Now, moving on to another tumor, and we see that this tumor sometimes an adult, which is PXA. Now, PXA, the new change in the WHO is that we have a new grading, which is WHO grade 3, anaplastic PXA. The PXA used to be graded as grade 2, but they found that some of them behave really badly, and they upgrade them, or they gave them a new entity. It's called an anaplastic PXA. So we have now PXA grade 2 and PXA grade 3. And this is a case that's also I've dealt with. I would say the PXA, most of them we have here were kids. This is one or two we have in adult. And this patient in 2010, he was 36, came in with severe headache, and we showed this big lesion in the left frontal with enhancement. So we did partial resection because it was quite extensive in the left dominant hemisphere, and the pathology came back as PXA. But our pathologist told me, well, PXA is normally grade 2, but I've seen a lot of mitotic figures in this tumor. So he called it PXA with high mitotic figure, because then the anaplastic was not available at that time, anaplastic PXA. So he was given radiotherapy. This is 1 year follow-up, it was stable. Then 3 years, there was evidence of recurrence and enhancement now, and it's more into midline and crossing midline, in corpus callosum. So I operated again, and the pathology came back as GBM. So it transformed actually to GBM. So it's an ugly disease. They survived for 4 years. What about ependymoma? Now, ependymoma, the only new change here, well, it's actually two changes. First one, we have a new entity for supratentorial ependymoma. Now, most of the ependymoma, they are the cere fossa and the fourth ventricles, but some of them rarely can be supratentorial, okay? And they removed some of the variants of ependymoma, like the cellular one, but the remaining, you know, the other types of ependymoma, sorry, I'm just having freeze now. So anyway, cellular has been removed. The other are the same, but we have a new entity, which is RELA fusion positive. So they found this tumor markers with the supratentorial only ependymoma. When it is present, it's a bad prognosis, okay? And in fact, interesting, I have one case that I've dealt with. It was an adult, 33, came with seizure. It was a cortical lesion, mixed density, solid and you know, cystic, which we resected completely. And for our surprise, it came back as ependymoma. And this patient had radiotherapy. Unfortunately, he didn't do well. Within 2 years, the tumor recurred. And I mean, we didn't have the tests, but I presume this is actually RELA fusion positive if I have tests, because it didn't do well. Within 2 years, there was recurrence, with extensive recurrence actually, and he's now on chemotherapy. He's still alive on chemotherapy. Okay, so this is an example of ependymoma supratentorial. So what happened now with meningiomas? Meningiomas, we have additional to in the new WHO classification, which is the adding one criteria for atypical meningiomas. Okay, so we have brain invasion. Brain invasion now is considered to be a new criteria to for atypical meningioma. So these are the criteria for atypical meningioma. Very important to distinguish meningioma of, you know, grade 1 from grade 2, because the management is very different. Okay, the certain subtypes of meningiomas, they be automatically grade 2, like clear cells or chordoid, high mitotic figures, brain invasions. This is new, and the minor changes in the pathology, and you should have 3 of the 5 changes here. If you have them, like necrosis, you can be upgraded to grade 2, and this is really important for us as surgeons. So we did this study as well in our hospital to see, how useful this invasion, brain invasion for classification or for upgrading meningiomas, because most of the atypical meningiomas that we've seen, they have increased mitotic figures with the brain invasions, but it's rarely to see upgrade of meningiomas to grade 2 based on solely or purely brain invasions. So we reviewed our atypical meningiomas to see how many of these cases were upgraded to grade 2 based on brain invasions only. Because this is, as a surgeon, it's important, okay? When you're dealing with meningiomas that have a lot of edema, and when you operate and you found, you know, the tumor is not actually well capsulated and has a clear border from the brain tissue in this area, there was possible invasions. That means you need to take some tissue from the adherent brain to, you know, confirm that this is atypical or there is, invasion, because this is important. So what did we found? We reviewed all atypical meningiomas. Over the last 10 years, we selected the aggressive meningiomas, and we found 3 of them were actually anaplastic, grade 3. 21 were atypical, okay? And these are the age and the sex. And then we found that 2 of the 21 that we have, they were upgraded to grade 2 based only on brain invasion, okay, 10%. Other studies I've seen, this study showed that 22% of atypical were upgraded based on solely brain invasions. Very important here to mention that brain invasion is actually a risk factor for seizures in patients with meningioma based on this study. So this is the new thing for meningioma. Brain invasion is now a new criteria for atypical meningioma. And atypical meningioma, that means you need to give radiotherapy, even if you do total resections, because recurrence is high. okay? And if you don't do total resection, you should give radiotherapy. And some schools will say, okay, total resection I can observe, but you have to closely monitor these patients. You do scan every 3 months or 6 months. But if you don't do complete resection, you should give radiotherapy, especially in skull-based cases. Now, other changes. Well, hemangiopericytoma, not very common tumor, but the new changes here is that they were included in this group of tumor, the solitary fibrous tumor. They found there's a similarity in the genetic basis, so they put them together. And now we have 3 grade for hemangiopericytoma. I remember hemangiopericytoma, normally it's grade 1 or 2, but we have now anaplastic hemangiopericytoma. I have one case, but I couldn't get the numbers in the picture, sorry, to present it. Lymphoma now upgraded because the lymphoma classification in the body has been updated. So they updated it because they are similar to the brain one. So these are the changes in the other common tumors in adults. So in summary, this is what I'm trying to summarize the common tumors. So this is the new WHO classification, okay? This is the list now with the grading. So again, look at this compared to the previous one, diffuse astrocytoma and oligodendroglioma. So it's one group now. Look at the IDH mutant for anaplastic glioma. Then you have glioblastoma, wild type or mutant. This midline glioma, we'll talk about it in the next lecture, in the pediatric. Oligodendroglioma has to be mutant, code deleted, or anaplastic. So this is one group, okay? The other one, this is the other group, the non-IDH group, which is pilocytic, grade 1, SEGA, grade 1, BXA, grade 2 and 3. Okay, we talked about this. Ependymal tumors, so subependymal, I was trying to remember. Grade 1, myxopapillary, grade 1, ependymoma, grade 2, and there was one clear cell was removed. Ependymoma, the RELA, this is a new entity, could be grade 2 and grade 3. Okay, and they have the anaplastic ependymoma. Other gliomas, they are rare tumors. Choroid plexus, no changes. The other tumor, DNET, ganglioglioma, no change. We have now anaplastic ganglioglioma. I think it's been in the old one. This is really a rare tumor. Again, central neurocytoma, now it's grade 2. I remember it was grade 1. Now, Pioneer, no change. Embryonal, huge changes, which will be covered in the next lecture, hopefully next week. Schwannomas, I think there was one change about this. I'm not covering this in this topic, unfortunately. Meningioma, you know, one change is the brain invasion. So we have 3 grades as before. Hemangioblastoma now is under mesenchymal. I think it was different category, but they are now under mesenchymal non-meningothelial tumors. Stella, you know, no changes. So this is a summary of all the common brain tumor with CNS according to the new WHO classification. So coming to the end now, it's really important to remember that you know, there are major changes, mainly in the glioma in adults, okay? And this markers, there's only a few markers we need, to be honest with you, till now, with the IDH and the co-deletion for gliomas in adults, and they are must in terms of prognostication and the definitive diagnosis, okay? Very important to understand the new language, new terminology we use now to describe tumor, histopathology followed by the genetic alteration or genetic mutation. The changes is even more in the pediatric, which we'll cover hopefully next week. It's very important now we have one language, okay, that everybody will understand with minimum of you know, examiner variation. So when you have a tumor coming from a lab tell you IDH mutant, there's no other way. It's only one test, positive or negative. It doesn't rely on the expertise of the examiner on the microscope. So we have one language. The variation between reporting and getting different reports is minimum now. And this will help for, collaborative works between labs. And then with this new advance in the genetic, change in the tumor, it will help also for therapy, because we have now target therapy for a specific gene alteration. And this is more, important in pediatric, and its future research and treatment. So the new classification gave us, a better understanding for the prognosis and behavior of tumor. And I would like to thank you very much for your listening, and thank you. I'm not sure if we can have time for questions now. All the questions.
We have another new question, Dr. Mahmoud.
Can't see this. Sorry, yes, which one?
We have a new question. Primary CNS lymphoma from radiological features. Mandatory biopsy, a question mark.
Yes, primary CNS lymphoma. So if you do the staging and you don't see other lesions in the body, and if it looks like a lymphoma, you need to do biopsy to confirm the pathology, because some GBM can look like lymphoma or vice versa. But more importantly, your oncologist will never give treatment, they will never give any treatment without biopsy. So unfortunately, at the end of the day, you are forced to take a biopsy, because your oncologist will refuse to give any treatment without pathology. That's our experience with our oncologist. Even for secondary, I mean, we've seen cases of secondary lymphoma, but because they are coming with solitary lesion, we were forced to take more biopsies from the brain just to make sure it's not something else. Now, another question, what about stereotactic radiosurgery and neurosurgery? Stereotactic radiosurgery and neurosurgery is a great tool, but we need to know the indication, okay? You cannot give stereotactic radiosurgery for gliomas, for example. It doesn't work very much. You can give it for metastasis, for meningiomas, for vestibular schwannomas, for pituitary adenoma, if you have residual. So there are indications. Stereotactic radiosurgery or radiotherapy is an excellent tool, and we should always think about it and give it as an option to the patient. If you have a residual of vestibular schwannoma far from the brainstem, and there's always a chance for stereotactic radiosurgery, you should give it to the patient. Metastasis, deep-seated near the motor area, again, excellent choice for, but again, it's all relying on, depend on the size of the tumor. It has to be small, less than 2.5. Now they are going more to 3 centimeter, but average has to be less than 2 centimeter. What does the IDH gene normally express for? It's found on normal glia on the tumor cell. It's actually in the tumor cell itself. So it's a genetic, it's part of the tumor genesis, if we can call it, because when the normal cell transformed into a cancer cell, there's a series of changes that happen that will lead mainly to do with DNA repair. So this is to do with DNA repair and certain mutation in the genes that can lead to propagation and transformation of the tumor. It's something complex. I can't explain it fully, but anyway, it is not a normal. It's something. Well, it is a normal product, but it's studied on the tumor itself. Okay, how long to repeat surgery for anaplastic GBM in young patient? How long to repeat surgery? Anaplastic GBM in young patient, repeating surgery, there are indications to repeat surgery. Now, it's really, it's individualized. I mean, there's doing second surgery in GBM, to be honest with you, is not standard, okay? Because now we have second-line chemotherapy. If the tumor recur in an area which you think it's safe to resect, you can do that, okay? Especially if it is progressing or causing mass effect or symptomatic, because sometimes with the follow-up, you can see recurrence and the patient is very well and he's still taking on temozolomide, he's still on treatment. It might be better to watch him and repeat the scan after 3 months, because some of them might have what we call pseudo progression and some of them improve with time on the follow-up. So normally I wouldn't go back again unless there is a true progression or recurrence and it is focal and not multifocal, okay? And it is an area safe to resect. And we did the study here actually comparing this with the second-line chemotherapy, mainly Avastin, and we didn't see a difference between second Avastin and our second surgery. The survival were similar. We've seen good results from Avastin with second-line chemotherapy. But young patient, focal recurrence, and it is symptomatic, you know, it is enlarging. Yeah, there is a place. Do you think the establishment of genetic histopathology is easy in all hospitals? It's not easy. It's very difficult. Unfortunately, it's not available. Genetic testing, unfortunately, we have only the basic ones now. For children, we don't have most of them. But I think there are certain places they have this genetic testing. And that's why if you in a peripheral hospital, you know, in a hospital where you do, this is really a great message, I need to say it here. If you do surgery for brain tumors and your lab doesn't do the markers, don't give them final pathology. Refer to another hospital, get the final pathology reviewed by, you know, neuropathologists. 30%, 30% of our reports coming from different hospitals are changed by our neuropathologist. Okay, so you have to be careful not to give final pathology if you are referring this patient to you know, oncology center or hospital where the oncology. Please tell them this is what we think, but it's better for the slides to be reviewed by the other hospital where you are referring for treatment, you know, because I can tell you the cases that we're receiving, 20-25% of the cases, the pathologists are changed. And I've got a lot of examples. So that's my advice. We have so many cases coming as low grade, and it's not low grade. Some of them were high grade, GBM. It was turned out to be different tumors. Okay.
Thank you, Dr. Taha. If we have the time, there's two other questions as well.
Yeah, no problem. I'm just not seeing them.
The first question is, how do you explain the changes in pathology in the first and second surgery?
Sorry, I can't see the question. Here. It's not coming here. Sorry. How do you explain? Sorry, say that the. How do you
explain the changes in pathology in the first and second surgery?
Well, if we talk about the cases I presented, the transformation is something well known. You know, you could do the first surgery if patient had low-grade glioma, and then the second surgery could be glioblastoma or anaplastic there, because low-grade glioma will transform. Anaplastic tumors, they do transform. They do change to glioblastoma. So this is normal. As for maybe the other, if you meant about the biopsy versus resection, in low grade. As I said, biopsy in low grade can be misleading if you take a sample from the area that doesn't enhance, or these tumors normally are mixed. Some area are low grade, some of the area are high grade. And I must say, what looks like, remember, tumors that looks like low grade on MRI, no enhancement at all. Diffuse astrocytoma, high in T2 and low in T1 with no enhancement, typical low grade. 30% of them, when you operate, they are high grade, anaplastic. Okay, remember this. In fact, in our region, or I'm not sure, our experience, that half of them, when you operate, they are not low grade. And that's why this is another indication why you need to do surgery of patients with low grade, because you need to make sure they are low grade, because 30 up to 50%, when you operate on them, the pathology, even if they are typically low grade on the radiology, 30 to 50% they are high grade. And also you need to do the markers now with the new, you have to do the IDH and the co-deletion. Another question, what's our possibility of referring SANS blocks for genetic study to your center? Yes, I mean, we have the IDH and the blocks, we can do them. Not to this stage now. With the corona crisis, everything is on hold now. But hopefully things will improve, inshallah, soon.
Another question related to genetics. Can we apply same concept for glioblastoma? I mean, with IDH mutation and wild type.
For what? Which tumor? Sorry.
Gliosarcoma. Sorry, I'm not a neurosurgeon.
Gliosarcoma. Yeah, gliosarcoma is IDH wild type. Okay, so it's not mutant. When the pathologist reported gliosarcoma, this is one variant of the IDH wild type. Okay, so there's no gliosarcoma mutant. Okay, mutant wild type IDH mutant is only for diffuse astrocytoma, grade 2, 3, and 10% of glioblastoma, which is the secondary one, it transformed from low grade. Okay, gliosarcoma, epithelioid, and clear cell, or large cell, sorry, glioblastoma, they're all wild type. They're not mutant.
Thank you, Dr. Mahmoud. There is another question just popped up. If we had time, would you like me to read it to you?
Yeah. No problem.
No problem. Is there a significant role for serum tumor markers when approaching a patient with brain tumor?
The serum one is not working. Okay, we cannot use the tumor markers in the serum yet. All these tumor markers are actually on the tumor itself, the samples, the blocks. We only do the serum blood test, tumor markers for germinoma, but not for the glioma. So far, we don't have, the genetic testing on the serum or blood for glioma. It has to be done on the tumor itself.
Thank you, Dr. Mahmoud. For now, this is the last question.
Okay, so, I mean, if you have any more questions, we can leave them to the next lecture. I mean, next week, inshallah, we'll be covering the pediatric. It's actually more exciting. There's a lot of changes in the pediatric brain tumor, more than the adult. So, we can leave questions to the pediatric one. Okay?
Dr. Mahmoud, a great presentation.
Thank you very much. And we'll see you next week, inshallah. Assalamu alaikum.
إن شاء الله. هيك